Hello, good day, everyone. I'm Dr. Iyore Edionhon. I'm a consultant and aesthetics intensivist. I want you to know me in case there is something that we can do together. I'm open for collaboration just to ensure that things are working well, especially when it comes to critical care or intensive care of the critically ill. I'm a fellow of the West Africa College of Surgeons. I'm a fellow of the National Postgraduate Medical College of Nigeria. I'm a member of the Intensive and Critical Care Society of Nigeria. I happen to be the author of Better Preventing Disease. It's an online media providing information for the people, for the masses, to enable them or empower them to be able to prevent diseases. For disease prevention is better than cure at all times. I'm the author of the Concept Medical Magazine. I happen to be the director of the Hospital Rescue Initiative, as well as the Community Health Conscious Concept Nigeria. I've been doing intensive care for the past 3 years. I have been trained to be able to prescribe organ support system for the people that are critically ill. When you talk about people that are critically ill, these are people that have need for 2 or more organ support system while awaiting recovery. In the intensive care unit, we support the respiratory system, we support the cardiovascular system, we support the central nervous system, we support even the musculoskeletal system, the gastrointestinal system. It's actually a place where we have multiple organ support system while we await recovery of patients that is being admitted into the intensive care unit. What that means is that for people that are admitted into the intensive care unit, they are people who have probably a recoverable illness. All right, that is why we have the criteria for ICU admission. I have been trained to prescribe mechanical ventilation to people based on their age, based on their etiology of the pathology that led to the admission into the critical care unit, and the involvement of the lung parenchyma in the ongoing disease. I am being trained to be able to offer safe driving pressures in ventilating your patient. I've been able to prescribe ventilatory modes to suit the pathology of my patient as it concerns lung conservation or lung protection ventilation, as well as having the anatomy that at the extreme of ventilation, you might have a need to position your patient at this time, talking about propositioning, in order to optimize the lung parenchyma and improve compliance in order to give better outcome with your patient that you are mechanically ventilating. At the extreme of this, then you'll be talking about extracorporeal membrane oxygenation. I've had the opportunity to work with a team of doctors who was in Glenfield Hospital, Leicester, one of the best intensive care units in the world. I was in their ICU. I was also in Royal Wolverhampton. I was in their ICU in the United Kingdom. I had the opportunity for observership in this ICU. I know what it is to have multiple organ support system. I know what it is to have cardiovascular support system. I was also there in the World State of the Heart Congress in Birmingham. This was a World Congress of critical care physicians, intensive and critical care physicians all over the world, as they gathered in 2023 in June in Birmingham, and the 2024 was in Liverpool, in United Kingdom. I've had the opportunity of having been trained for mechanical ventilation physiology and application. I just finished a course in Toronto. Okay, I had the opportunity of being part of that mechanical ventilation course or symposium that took place in Toronto. I have the opportunity of having to be in a medical team of doctors, even in Nigeria. All right. Like I said, I'm a member of the Intensive and Critical Care Society of Nigeria. So I'm also a member, by extension, a member of the World Federation of Critical Care Physicians. They actually organized another training, which I was part of, mechanical ventilation and hemodynamics monitoring. And there we were trained to on the need to use echocardiogram. So what are the things that I can do? I can do multiple organ support system. I can do invasive blood pressure monitoring, central venous pressure monitoring. I can use the ultrasound for this procedure. I can use the ultrasound to assess the adequacy of fluid resuscitation, or even to see whether the patient have got pericardial effusion or bilateral pleural effusion. I can reasonably use the ultrasound. I can also use the echo machine when you talk about accessibility of adequacy and some level of function when it comes to cardiovascular system. I can use the echocardiogram. What are those other things that I can do? I can actually do a percutaneous tracheostomy. I can use a bronchoscope. I've been trained when I went to Birmingham. I've been trained to use the bronchoscope. I can do bronchoscopy. I can do a bronchial lavage and sampling. I can do bronchial suctioning under vision. That is using the bronchoscope or the flexible fiber-optic bronchoscope, and most times it's disposable. The one we have is disposable. I can also do sampling for histology, microscopic culture, and sensitivity. So when you have a patient who got an extreme of respiratory disease and getting to ARDS, I've been able to safely ventilate such patients in my ICU with safe driving pressures and long preservation ventilatory mode and ventilatory parameters, and long recruitment ventilation, and this patient actually going home. For patients who succumb, I've had the opportunity of being part of that team, like I said, in Glenfield, and they were connected to the extracorporeal membrane oxygenation. I don't think there's a unit or a system or a center in Nigeria where patients have been connected to extracorporeal membrane oxygenation. I've had opportunity of being in that team. I have the opportunity of being a team of world-class critical care physician who have cared for patients in a closed ICU. Okay, although I work in an open ICU here in Nigeria, but I've had the opportunity of being in a closed ICU in 2 centers of the world, like I said, in Glenfield and in Wolverhampton, where you, as an intensivist, you do cardiology, you do respiratory medicine, you do neurology, you do even infectious disease. As at the time you are done with your patient in the ICU, then you inform the managing team that you are discharging their patient down to the world. But in Nigeria, I think there are few ICUs in Nigeria that are actually running a closed ICU. Because for you to be able to run a closed ICU, you need adequate training for those systems so that you'll be able to support care before you de-escalate care from the intensive care unit. As an intensivist, there are critical areas I will advise other intensivists that must be looked into. That's actually a game changer when it comes to caring for the critically ill people. Do you know that as an intensivist, this area you might not look at them as being as important, but as a matter of emphasis, I have this message for critical care physicians that physiotherapy is as important as cardiology, as intensive care, as neurosurgery in any institution. I was like where I've been to in other places of the world. I saw a patient with chest tube mobilizing, a patient with mechanical ventilator connected to a tracheostomy port mobilizing. Mobilizing out of bed is a major component of care that we must not underrate as critical care physicians. Do you know that thromboprophylaxis is not 100% offering your patient prevention for DVT and subsequently pulmonary embolism? If you must completely rule out pulmonary embolism, or if you must completely prevent pulmonary embolism in critically ill patient, you must be determined to mobilize your patient as soon as possible. Putting everything together to ensure that your patient is off the bed is another class of care. Except it is contraindicated, nutrition is also as important as every other area of medicine in terms of caring for the critically ill patient. What do we do in the intensive care? In the intensive care where I've worked, we do neuro support system. After a major neurosurgery, we help our patients recuperate, and we talk about care that you offer to control the intracranial pressure to ensure that to all extent we prevent secondary brain injury, irrespective of what has brought the patient in terms of the primary injury, whether it is trauma, whether it's from stroke, whether it's from chronic bleeds or whatever it is that is the reason why your patient have come. You must be ready to offer clinical care that will prevent raised intracranial pressure. In order to prevent secondary brain injury, you must ensure that your patient too is well oxygenated so that hypoxia cannot come in, acidosis will not come in. I understand the fact that you might do some permissive hypocapnia in order to control intracranial pressure, or that we do. We are able to support the respiratory system by mechanically ventilating our patient with safe driving pressure, with long recruitment ventilation, with long preservation ventilation, getting to proning until you get your patient reversed or getting to the need of extracorporeal membrane oxygenation, which we don't have yet in this country, but I've had the opportunity to work in there. So for patients that are invasively monitored, for patients, we are able to support the cardiac system, all right? For cardiac For the cardiovascular system, inotropic support. When it is sepsis, we know what to do. When it is cardiogenic shock, we know what to do. When it is hypovolemic shock, we know what to do. We are able to adequately support select inotropic, chronotropic, and vasoactive substances to meet the demands of our patient when it comes to cardiovascular. And again, we have an intervention. I've had the opportunity of working in a place where we have a functional interventional cardiology. Like I've worked in a place where there is functional cath lab, and then I've seen prompt intervention in doing intracardiac interventions radiologically, when you have to do stenting, you have to do thrombolectomy, and many more. Okay, so I've had the opportunity too of working in a place where you have to get to do invasive monitoring. I do both non-invasive and invasive monitoring. When you talk about invasive monitoring, interarterial catheterization, and blood pressure monitoring, and we do central venous catheterization and central venous pressure monitoring, and how we are able to relate that to your clinical improvement or deterioration of the patient. And we also do non-invasive non-invasive monitoring, where we talk about the capnography. I am able to use capnography to make diagnosis and also to monitor my patient. I have worked in some ICUs in Nigeria. I've had the opportunity of working in the ICU in the Jos University Teaching Hospital. I've had the opportunity of working in the ICU in the University College Hospital in Ibadan, where I did postings. And then I have the opportunity of working in the ICU where I am now, where I'll give it to the center where I am now, because it's a center that supports human development. In fact, I have been involved in some researches because of what we have done. We have the opportunity of managing a patient with malignant hyperthermia that was referred to our patient. I'm writing a case report on that. And I've had the opportunity of managing a sickle cell disease patient with acute cerebral syndrome, who actually presented blind, deaf, and aphasic. Okay, now all these were reversed. I'm actually working on a case report in that regard. I'm working on a research too, looking at us as one independent risk, okay, that compromises the outcome of sepsis in the elderly. I'm looking at that, and I'm putting a lot together to ensure that works. Okay, talking about human capacity building, I've put in time to be in conferences of the world. I've had a course of continuous renal replacement therapy. I was trained by Sundarbet, and I have a certification to that effect to be able to prescribe and offer the treatment using the continuous renal replacement therapy, using the Prisma Flex machine. And this continuous renal replacement therapy offers a better renal support to the critically ill compared to the regular hemodialysis. This is because the continuous renal replacement therapy is soft on the hemodynamics. It is slow and it takes a longer time. Because it is slow, critically ill patients who cannot tolerate significant hemodynamic shifts are able to tolerate continuous renal replacement therapy. Like those world-class ICU that I have worked, that I have observed, like I told you, they are able to give renal replacement therapy. The intensive care physician, they are able to offer that. They don't need to wait for nephrologists to be able to prescribe that. They give it to patients post major cardiac surgeries, post major neurosurgeries, just to support while awaiting adequate post-op recovery and optimization of such patients. Coming to intensive care. Intensive care is in my blood. It's something that I have loved to do. If we all abandon the care of the critically ill in our nation because of what reward we are going to get, we are going to leave this nation in the hands of nobody. And because this is our fatherland, we've got no other place but Nigeria that I love. We will keep empowering ourselves to be able to give quality of care. It is very expensive, I tell you. You putting your money together, your hard-earned money together, converting them into foreign currencies to be able to get trainings, to be able to get experience and exposure in order to impact the health of the critically ill in your nation. It's a lot of sacrifice. It is possible that a lot might not see it. A lot of people, a lot of institutions, a lot of employees might not see that. And for you who know how much you are putting in, you must give it back to the community. You must give it back to the people, so that the satisfaction you get from people turning around from a critically ill perspective to one who is now going to the world and then to their homes. That is the satisfaction. That is the satisfaction and the reward that you get as a critically ill physician. As a critically ill physician, I put before you that critical care is like a calling. This is because it is very demanding psychologically, it's very demanding emotionally, it's very demanding in terms of your knowledge. There's a thin line between critical care and the other side, and so you must be sure that you're at your best at all time. You don't leave it to chance. You don't leave critical care to chance. You must be on top of your game at all times, because for every slip or for every mistake is going to cost you something you might not be able to get back, because there is no physiological reserve in the critically ill. In coming to the critically ill, you must know that the critically ill individual, the critically ill patient, are one that are having multi-drugs. If you look at the prescription paper or prescription charts of the critically ill, you see multi-drug. They are polypharmacy. You see a lot of drug. If you must be a successful physician, you are the one that will look at the drugs of your patient. You must ensure that you have studied their drug-drug interaction. Otherwise, it is possible that the patient you have in the ICU is manifesting the side effect of the drugs you're giving them if you're not careful. It is also possible that you'll be giving drug to the critically ill, and there's another drug that you're giving that patient that is counteracting the effect of the other. So what do you do? As a critically ill physician, there's another part of your patient's care that you must pay attention to. The drug, you must study the drugs that your patient are on in order to prevent a drug-drug interaction, in order to downplay side effects of those drugs, in order to remove those drugs when they are not appropriate. For example, there are several drugs you don't give to a patient you are supporting with renal dialysis. What am I trying to say? A patient with renal impairment that you are supporting, there are drugs you should not give to that patient. There are drugs you don't give to a cardiac patient. There are drugs that are for sepsis, inotropic support, and there are drugs that are for cardiogenic shock. So you must be one that review, as a clinical care physician, you must be one that reviews your patient's medication at each time. Otherwise, the drug can be the one working against you. Have you checked your patient drugs today? This is Dr. Iyore Edionhon. If there's something you want us to do together, please feel free to contact me. My number will be somewhere here, because we need to collaborate to ensure that we put our knowledge together to better the care of the critically ill in our country. You see the outcome that people are getting all over the world. We should be able to improve that, because we got no other country, we got no other home. Nigeria is our fatherland. We must study to show ourselves approved. We show ourselves worthy to be able to present a quality of care to our critically ill or to the sick in our country, such that we can stand tall with other countries of the world in terms of the quality of care that we are rendering. Please have a great day. Don't forget, I'm here for collaboration, for working together, just for the purpose of improved quality of care for the critically ill. Thank you. Bye.